Hi, my name is Bhandal and I'm the CEO of RSB Events. I run the National Substance Misuse Conference. I've been asked by a collective voice on an opinion piece around why there is underrepresentation of BME populations in treatment. I've been waiting to do an article or vlog for this for many years, as I've been involved in the treatment system for over 15 years. So what I'm going to do is just going to give you my opinion on why I think this lack of engagement within BME population, this underrepresentation, is happening and occurring. And finally, at the end, some of the recommendations. As a Punjabi Sikh, anecdotally, I've known within the community and culturally that alcohol has played a massive part. When I look at some of the statistics that are produced by NDTMS, particularly, let's take for example for this vlog, the 16-17, March to April, I can see many different variations in the treatment numbers that are in there. It says in this year, approximately 280,000 people have entered the treatment system. Out of that 280,000, less than 1% were from an Indian background. Take a look at the NDTMS table that I've put up for you. The NDTMS data shows the ethnicity of all clients in treatment from 2016 to 2017. If you look at the Indian, Pakistani or other Asian categories, they total up less than 3% of the total population in treatment. So, why is there underrepresentation from BME populations in treatment? Well, I think this is a historic argument that's been happening over a long time. And the issue that I have is anecdotal data versus actual data. So anecdotal intelligence with actual real intelligence from commissioning to actually set these whole systems up. Let's look at it from a first angle. What we're really talking about is how do providers, commissioners actually engage with their populations. And people from the BME background don't tend to have really good engagement rates, not just only in the substance misuse field, but across the board. So that's looking at it politically, even with other public health treatment systems that they provide. In terms of how we're looking at moving forward, what would we be doing? One of the things for me that would actually implement real change is having local champions within the community. That can all be done by actual true engagement within that population. At the moment, what I feel that happens is that you'll have a provider who would only go in on a festival date or an important date within a particular faith, set up a stall, highlight various kind of campaigns, and then basically pack up and see you later. What I feel in order to move this forward is having those real, local, credible champions who may have gone through the system themselves, may have some expert knowledge in the whole area, but be that point of contact for communities to actually go up to and get that help and support, be it signposting, being that conversation, most importantly having that real presence. One of the other recommendations is actually having that real change in hierarchy. Now what I mean by that is if you look at the providers that are actually out there, how many of the senior management, the chief execs, etc. are from BME backgrounds? For me, being in this field for 15 years, there wasn't that many people from my background. So having those real role models were very difficult to kind of find. And I feel that actually having many people from different kind of backgrounds will be the first step to try and breaking down those barriers and getting people to aspire to those positions of trying to maximize influence within their own communities. One of my final points that I want to raise may seem a little bit controversial, but it's a very important issue for me. I understand that there is a real huge pressure on trying to engage stigmatized communities out there, BME communities being one of them. But if you're a provider and you're commissioning out a service that is aimed at these populations, how do you know it actually works? How do you know those interventions are actually working? How do you know that there's actually any credibility with it within the communities that they serve? These are the little things that might push these populations away, but what we're trying to do is trying to attract them in. Because we know that in the extreme end, 80% of drug-related deaths come from people who are not engaged into treatment. And my fear is the less BME populations actually engage, the risk of drug-related deaths increase. I also take on board that within these communities, stigma is a huge issue. However, I do also feel that that cannot be singly blamed for why engagement does not increase into the treatment system. There is also an onus on some of the community in order to try and actively get involved. We must do better in terms of bringing our engagement forward. On reflection, I don't think that the actual individuals involved or the providers involved are intentionally disregarding these communities. These are only a few of my recommendations based upon my own personal experience. I'm happy to have this conversation with the widest audience possible. So maybe one time in the future, we may be able to get together and discuss how we actually increase the populations of BME communities into treatment. Thank you.